Very good afternoon. My name is Hui from the National University Hospital in Singapore, and I've been asked to proceed straight to the kidney transplant and the urinary recon session for the afternoon. So after a morning of endourology and oncology, we're going to change gear to have a mini session on kidney transplantation. It gives me great pleasure to introduce Dr. Valerie Gan, who is a surgical director for the kidney transplant program at SingHealth Transplant at the Singapore General Hospital. And she is a passionate surgeon in transplant, also the residency program director for SingHealth Urology, and did a fellowship in Cleveland Clinic in urology and transplant. So she's going to tell us about the challenges of performing kidney transplants during the last 2 years of the COVID-19 pandemic.
Hi, good afternoon, everybody, and thanks, Hui, for the introduction, and thank you to the organizing committee for this invitation to speak today. I was asked to speak about how our program navigated through the tribulations of the past 2 years. I must admit that this topic is veering a little bit off my usual surgical transplant talks, so please bear with me if there's like a lack of exciting surgical videos. Okay, so this is the outline of my talk. I will be covering how we pivoted our program to ensure that we had continuity of care for our transplant patients, and I will touch a little bit on the impact of COVID-19 infections on transplant patients as well as on our program. So a brief recap of what happened on the international stage, which caused WHO to declare a pandemic in early March. So as you can see, transplant patients were affected very early on, and this is not surprising because Wuhan actually has a large volume of transplant patients, okay? And I think it became fairly obvious quite quickly that this pandemic was not going to be as short-lived as SARS. So this is just a big overview of what happened on the global stage. You can see there's about an 18% decrease in overall transplant activity across all the organs in 2020. And specifically for kidney transplants, there was a further drop by 21%. So in Singapore, we went on high alert very quickly when the first local case was detected on the 4th of February. So besides the government raising the DOSCN levels to orange and implementing a circuit breaker later on, our Ministry of Health also very quickly implemented certain advisories which were specific to transplant activities. So it was a bit of a yo-yo. Initially, we were told to suspend all disease organ activities. And then we were told you can go ahead with disease transplants, but you have to suspend your living programs. By July, we were allowed to continue with all our transplant activity. Of course, the caveat being that each transplant center would have to decide whether they could accommodate if we had enough resources. So what are the considerations that we should take into consideration if we were to carry on with a transplant program in the midst of a pandemic? So on the one hand, of course, you know that if you were to carry on, you may expose our recipients as well as the living donors to potential infection. And you would also be competing for very limited resources. On the other hand, if you were to completely stop doing transplantations, you would subject your current waitlist patients to morbidity and even the risk of increased mortality. And of course, there would be available organs that would be discarded and go to waste. So what's so special about renal transplant? In general, of course, it is known that renal transplants are not as urgent compared to other solid organ transplants because our patients can actually remain on renal replacement therapy. Having said that, there are actually a couple of indications for urgent renal transplants. The plus point for us, I guess, is that renal transplants actually use up less resources compared to all the other solid organ transplants. I'm sure we're all very familiar with this, right? First tenet of medicine is to do no harm. So if we were to continue with transplantation, we need to be very aware of the potential for donor-derived infection, okay? And we also need to consider that our very immunosuppressed patients are at increased risk of getting infected and may have worse consequence than the standard patient. So having taken all of this into consideration, we went about revamping our work plans and of course implementing certain plans to try to ensure that everyone worked within a safe environment. So of course for our staff, like most hospitals, everyone went into split team mode. We were very careful not to have cross-contamination between the teams managing acute transplant cases with the teams that were covering COVID patients or COVID suspect patients. I'm sure most of you here also remember the very uncomfortable times when we were subject to daily temperature taking as well as very frequent PCR swabs. So that was not much fun for anyone, but it kept our patients as well as our staff safe. We also very quickly adopted telemedicine, and here you can see one of my transplant coordinators running a virtual counseling session with the patient, and we even arranged for medication delivery. And all this was with the hope that our immunosuppressed patients can limit their number of visits to the hospital. We also ran quite a few education webinars, and this was how we very quickly reached out to all the transplant patients to give them early advice as to what they should be doing to protect themselves, what they should do if they really got infected. And of course, we also use this platform to drum in the need for vaccination amongst this group of patients. So this is just a screenshot showing you one of the webinars that we ran. This was by our infectious disease physician. So he was giving a talk on importance of vaccination and what the vaccination schedule may look like for our transplant patients. We even have to revamp the physical flow of patients within our transplant center because we were trying to limit the physical contact between the high-risk patients as well as the low-risk patients. So manpower was very tight, obviously, with my transplant surgeon and transplant physicians all being deployed to the front lines. And here you can see even my transplant manager was not spared. She was deployed to man the fever booth at the entrance to the hospital. So the other problem was that we had a global supply chain issue. We had to be very careful to ensure that we had sufficient drugs and plasma exchange kits if we were to carry on. And everyone knows that the operating theatres and the ICU beds were very hot commodities. So, before we carried on, we had to ensure that, at any one point of time, we had sufficient resources. So one thing I think that helped was we decided early on to avoid completely doing high-risk or incompatible transplants because these are the cases that generally eat up more resource, and this is also precisely the group of patients who are most immunosuppressed. So theoretically, they would be the most susceptible group to infections as well. Nationally, we agreed on a standard organ screening and allocation protocol as well, and this was again to try to decrease the chance of getting a donor-derived infection. Later on in the pandemic, when we noticed an increasing number of transplant patients getting COVID, we created this virtual ward, and this actually allowed the stable patients to be managed at home with regular teleconference and monitoring rather than routinely admitting all of them as we were doing at the beginning of the pandemic. Of course, there were provisions to do outpatient blood tests and also a quick pathway to admit them the moment we felt that they showed signs of deterioration. So what did COVID-19 do to our patients? This shows you the natural history of the infection. The solid lines represent the general population, and the dotted lines represent transplant patients or immunosuppressed patients. And you can see that the virus actually hangs around a lot longer in a transplant patient. This is quite common sense, I think. And also the immune response, as expected, is much dampened. Okay, so they do not mount as many antibodies, even despite having an infection. So we were all very concerned with the earlier reports that came out, which quoted mortality rates as high as 30% for transplant patients. However, now we know with more data and after a lot of time has passed that the mortality rates are a lot lower, and it is quite comparable to general population. So why this discrepancy? Some of the reasons may be better diagnostics. Okay, of course we have to credit vaccination and the new treatments that we have, and also perhaps our transplant population being kind of used to the pandemic situation and understanding that simple methods like wearing a mask is very important for their safety. So prevention is always better than cure. We try to get all our transplant patients vaccinated. Just to take note that primary vaccination series for our transplant patients locally is defined as having 3 shots rather than just 2 vaccines like the normal population. And again, this is because we know that they do not mount an adequate immune response, and it's been shown that even with 3 doses, their antibody levels are still lower than the general population. Okay, for those who are not eligible for vaccination, we have the option for pre-exposure prophylaxis. This is using monoclonal antibodies, preformed antibodies. But what happens if they do get infected? Okay, so the baseline treatment for most of them, if they present early, are antivirals. And the commonest one used here is, of course, the remdesivir. I'm sure most of you are familiar. The way it works is basically you want to try to dampen the viral replication for the early stage. And if they go on to develop more serious disease later on, then we will consider using steroids or even other monoclonal antibodies. And all this is in the hope of dampening the excessive inflammatory response, which is actually responsible for the poor outcomes in certain patients. So what do we do with their immunosuppressants? In most cases, if it's mild, we should actually keep the current immunosuppressant. For the moderate and severe cases, we generally consider reducing or even holding off the antimetabolites. Reason being, those actually cause a drop in the lymphocyte counts. Okay, so lymphopenia is actually a well-established poor prognostic factor in patients who get COVID-19. So can the virus actually be transmitted through donor organs? Well, if you were to look at post-mortem studies, the answer is yes, but clinically, so far, no, we haven't seen them in kidneys. We have seen such transmission in lung transplant recipients. Okay, so most of the international guidelines now say that having COVID-19 is actually not a contraindication for organ donation. So this is a paper that was published very early on last year from the Cleveland Clinic group. They reported 10 transplants done from donors who had COVID-19. And very recently at AUA, they actually updated their numbers to show 55 cases done already. And so far, there's been no cases of transmission. Okay, so lastly, how did this pandemic affect our transplant program? I think this is quite obvious. Our workload did drop quite dramatically, both in terms of referrals. You can see 2020 was a big drop, and in terms of actual transplants performed last year. 2021, I must say we caught up quite quickly, and now we are almost back to full steam. So I think this was the first recipient who really tested how good our screening protocol was. Okay, she was admitted with organ offer. Okay, and she came in and we did our screening, which of course consists of chest X-ray as well as a PCR swab. So we thought her chest X-ray looked a little bit hazy. She was completely asymptomatic at this point of time. So even before the PCR came out, we did a CT thorax, and this is what it looked like, right? So very florid changes, and it took almost 3 days for her to show any signs of infection later on. Okay, and of course her PCR later came back positive. So this was a case that I would say, I think we averted a disaster if we were to transplant her. I'm happy to say she recovered. 7 months later, she got her transplant and she's doing very well. It's actually quite amazing. If you look at this, in 2020, we did not have a single transplant patient getting COVID. The cases only started picking up in 2021, and that you can see closely mirrors the total number of cases that happened in Singapore, and Omicron seems to be very transmissible. So far, we have had 8 deaths, but none of them are in recently transplanted patients. Early inpatient experience, we had 10 cases admitted, all were very mild, okay, except for 2. And the only thing I want to draw your attention to is that the median time to cycle threshold of more than 30 actually doubled that of a regular patient. Okay, so they took a longer time to mount a response. How about the virtual ward that I talked about? So we had a conversion rate of about 15% ended up with the admission, but none of them passed away. And these were the predictors of admission based on our unpublished data. The only bright light to come from this is that we had a lot of opportunities to publish. Okay, so one of our publications basically looked at, it was a survey of our transplant patients across all the organs, and we wanted to see if they would be willing to take an organ, even early on in the pandemic when there was a lot of uncertainty. And actually 80 to 90% of them said yes, they would carry on with a transplant if they were called up. Okay, so in summary, I think it is definitely possible to carry on with transplantation during a pandemic, but of course we have to ensure that all these factors are taken into consideration. Okay, the main important thing is actually to ensure the safety of both the transplant team as well as the patients. So I have to give some acknowledgement to my renal transplant colleagues for some of the data that you have seen, and I thought I'd end on a happier note. This is a picture of my transplant team's first social gathering after a long 2.5 years. So thank you very much.
Yeah, thank you very much, Dr. Gan, for the excellent review. Can I ask if there are any questions from the floor? No, maybe I have a question. Can I just ask, what's your opinion now of taking either deceased or living donors who had either acquired COVID recently, and how do you feel about that?
I think right now there's quite a lot of data on at least recovered patients. So patients who have recovered from COVID, I think it's quite established that it's fairly safe to take their organs. Again, like I said, even for patients who have active COVID, right now we haven't had a single clinical case of donor-derived infection. So, but many of the centers have come up with their own criteria to consider. So some of them will not take patients who are clinically ill. They will only take patients who are asymptomatic but are swab positive. Of course, there are those who are more gung-ho, and they would take even patients who are symptomatic. But most centers are okay to take recovered patients right now.
Okay. Thank you very much, Dr. Gan. Next, it gives me a great pleasure to introduce a close friend of mine, Dr. Claude Reynold. And I think I've actually known this guy for at least more than 15 years since we were working together at the National University Hospital. And now he is at Kutipah Hospital and a senior consultant there. So he's going to come and enlighten us on how to prevent renal failure in Singapore in 2022. Thank you.
Good afternoon. Thanks, Hui, for the kind introduction. It gives me pleasure to be here, and I wish to thank the committee for inviting me to share some perspective on preventive nephrology in Singapore in 2022. So this is the outline of my talk. I will describe the local burden of renal failure, identify major contextual risk factors, review traditional preventive measures and their limitations, examine recent advances, focusing mainly on DKD, and determine what more can be done. The main focus of my discussion will be prevention of CKD and ESRD, and not so much of AKI, given the public health importance of the former. So this cartoon illustrates the common pitfalls we see in CKD care over the past few years and where it has gotten us. We do know that patients with early phases of CKD and also at risk for CKD are managed primarily at the primary care level. We also do note that there have been gaps in the past in patient CKD awareness, poor risk factor control, lack of risk stratification, reduced adherence to evidence, and multidisciplinary care approach, leading to a lot of those patients being referred to nephrologists when it's often too late, and not much being able to be done except for renal replacement therapy planning. Indeed, when we look at ESRD prevalence in Singapore, it's one of the highest in the world. In fact, based on the latest US renal data system, 2019, we top the top 5 countries in the world. And one of the main reasons for this is because we have a highly endemic prevalence of CKD risk factors. And if you look again at data from the most recent Singapore National Health Survey 2019-2020, diabetes mellitus, for instance, has a 10% prevalence, hypertension, 35%. And this is also compounded by the fact that we have an increasingly aging population. And we could also be doing better when it comes to screening for chronic diseases. In fact, when you look at diabetes, which is a major protagonist for chronic kidney disease in Singapore, about a quarter are left undiagnosed and or treated suboptimally. So it's not surprising to find again that about 60 to 70% of patients on dialysis or who have had transplant, the cause is actually diabetes in origin, prompting the government in 2016 to wage war against diabetes. So this is what the enemy looks like. So you can see a very diffuse nodular sclerosis, the so-called Kinsey-Wilson nodule, which is at the root of the heavy proteinuria that we see in diabetic kidney disease. And at the top there, you can see the diffuse interstitial fibrosis, which is at the heart of the irreversible decline in GFR that we see also in those patients. We do know that sustained hyperglycemia has hemodynamic impact on nephrons in the form of vasoconstriction of the efferent arteriole and also loss of tubular-glomerular feedback, leading to vasodilation of the afferent arteriole. And this leads to build-up of glomerular hypertension and ultimately severe proteinuria. We also do note that there's a biochemical impact as well, whereby through activation of the mineralocorticoid receptor, you have increased oxidative stress, inflammation in the interstitium, fibrosis, and ultimately reduction in the GFR. So traditional preventive strategies actually have focused at addressing some of those pathogenetic pathways, namely aggressive early glycemic control and blockade of the renin, angiotensin, and aldosterone system through use of RACE inhibitors or ARBs to reduce intraglomerular pressure and, in effect, try and control albuminuria. This table illustrates some of those pivotal trials that seem to address some of that particular therapeutic approach. And you can see from here that we managed to achieve at least a 30 to 40% reduction in albuminuria using this strategy. But it's not enough. We do know that there are still certain gaps, mainly in the form of over-aggressive blockade of the RAS system. Especially the on-target trial did show that if you block the RAS system with both an ACE and an ARB, be it in the form of telmisartan and amrapipil, you tend to get more renal harm than renal good. And similarly, if you try to achieve aggressive glycemic control when the patient is very advanced in the diabetes, you also get an increase in mortality of up to about 22%, as shown through the Accord study. So it's about putting the brakes at all points. So over the past 8 to 10 years, we've been able to see an emergence of evidence that shows that if actually you block reabsorption of sodium and glucose at the proximal tubule, using agents like SGLT2 inhibitors or gliflozin, you can restore tubular-glomerular feedback through vasoconstriction of the afferent arteriole, and thereby reduce intraglomerular pressure and reduce proteinuria. Similarly, if you block the mineralocorticoid receptors with novel non-steroidal agents like finerenone, you can reduce the onslaught of the interstitial inflammation. So these infographics actually illustrate the evolution of this new strategy using those novel therapeutics from about 2015, when we started off with use of empagliflozin in the EMPA trial, which was also a cardiovascular trial, to the use of dapagliflozin in the Credence and Canvas trial, and the use of dapagliflozin in the DAPA-CKD trial about 2 years back, the use of finerenone in the FIDELIO trial, which I'll talk a bit more about later, and lately the EMPA kidney trial, which was just wrapped up about 3 months ago, and we're hoping to see the publication hopefully in late October. Now, if you compare this to the world of oncology, where innovations and breakthrough are seen on a yearly to 6 monthly basis, it took us about 15 years to get where we are right now. But the good thing about this, these are more robust trials. Okay? They don't just address renal failure prevention in diabetic patients, but also in non-diabetic population. Indeed, the DAPA-CKD trial had about 8% of the patients there with IgA nephropathy, making it the largest IgA trial ever. So let's look a bit more closely about the impact of using gliflozin. In fact, the term I prefer using now is flozination. Hopefully we'll see it in the Webster dictionary soon. And this is actually the forest plot from most recent meta-analysis on the use of all the gliflozin's trial that ever been done. And what you can see here, you can actually achieve about 30 to 40% reduction in composite renal outcome risk with the use of this agent, not just in type 2 diabetic patients, but also in patients without diabetes. And the results are also seen, similar result impact is also seen in patients who have GFR as low as 30 mils per minute. It's a paradigm shift, and it's something that's been long in the waiting. Now, going back to finerenone, this is actually a slide on the FIDELIO DKD trial, which showed that you can also achieve a more modest 18% risk reduction in composite renal outcome when you use finerenone in a diabetic population with GFR as low as 25 mils per minute and proteinuria as high as 5 grams per day. And I'm happy to announce that about 3 weeks ago, finerenone was approved for use in Singapore, adding on a new weapon in our fight against diabetic kidney disease. So where are we right now in 2022 when it comes to diabetic kidney disease management and prevention? This slide actually was taken from the Kidney Disease Improving Global Outcome website. They are yet to publish this, but it's an updated strategy, a three-pronged strategy on how to combat diabetic kidney disease. Firstly, it's about lifestyle modification, smoking cessation, losing of weight, and so forth. And secondly, it's about intervening with evidence-proven agent which reduce glomerular hypertension, mainly RAS blockers and gliflozin. And thirdly, a more targeted approach of using finerenone, or in some instances, glucagon-like peptide agonists like liraglutide in patients with persistent severe proteinuria. But I think much more can be done. And it's more about translating what we have from evidence or from clinical practice guideline to real-world practice. So here we have what we published about 4 months ago from our own center in Yishun Health on the use of gliflozin in a multidisciplinary setup whereby nephrologists and diabetologists work hand in hand. And it was about a retrospective study whereby about 1,600 patients who had gliflozin, whether in the form of dapagliflozin, canagliflozin, or empagliflozin, where the renal outcomes were compared with patients who were on standard therapy. And despite all the flaws of a retrospective study, we were able to demonstrate a significant reduction in renal outcomes using such an approach. At a more macro level, it's about translating or pushing up the prevention strategies more upstream. So the holistic approach to lowering and tracking chronic kidney disease, or as it's aptly named, Whole CKD program, was launched in 2017 by MOH across about 20 polyclinics in Singapore. Its main aim was actually to increase awareness of CKD both among patients and doctors using care coordinators, aggressively screening for CKD in patients at risk using very inexpensive biomarkers like creatinine and urine creatinine ratio. And in those in whom CKD is discovered, they were then streamlined into different therapeutic or preventive strategies, be it in the form of lifestyle modification or therapeutics proven through clinical trials. And here I mean RAS blockers and SGLT2 inhibitors. Whole CKD was very successful. It was supposed to end, the financing was supposed to end in 2019, but it has, I'm happy to say it was extended for another 5 years because of the success of the program. How about the remaining 30%? So this table actually summarizes some of the other innovations, not at a grandest large scale as the DKD trials, of some other strategies that we can actually use to prevent or mitigate the CKD in patients who don't have diabetes. A good example is the use of febuxostat, which is a xanthine oxidase inhibitor, in reducing asymptomatic hyperuricemia, which we know is a risk factor for CKD. Use of sodium bicarbonate supplementation in patients with metabolic acidosis, which is also another known risk factor for CKD. The use of bariatric surgery, although this has not been proven through any form of randomized controlled trial, to reduce kidney failure, and the use recently of glucagon-like peptide antagonists, receptor agonists, also to treat obesity in this population. Use of acute kidney injury transition of care clinic or AKI clinics to monitor patients with AKI, in whom we know have a high risk of having CKD as well. Introduction of better and cheaper biologicals like rituximab, which can increase remission rate of certain forms of acute glomerulonephritis. And we mention again here the use of SGLT2 inhibitor to treat not just IgA nephropathy, but hypertensive nephropathy or even FSGS as well. And in the private sector as well, there's been increasing use of vasopressin antagonists, tolvaptan, to reduce cyst growth in patients with APCKD. So what does the future hold for us? I think the future looks very bright. And it's about leveraging and harnessing new innovations, be it in the form of big data, artificial intelligence, given that now that we are in an era of medical digitalization, looking out for new novel biomarkers so that we can better risk stratify our patients and also assess how they will respond to treatment and how the treatment is, how efficacious the treatment itself is. Singapore has leveraged itself, has positioned itself to that prospect with the launching of the Dynamo study about 4 years ago. This is a diabetes study in nephropathy and other microvascular complications, a large multi-sectoral study involving about 25 institutions, financed to the tune of about $25 million. And its grand aim is actually to identify new mechanistic pathways in DKD, discover and validate potential new targets for treatment, and define novel biomarkers so that we can actually even try and reduce prevalence of DKD by about 30% in 5 years. So in conclusion, in 2022 in Singapore, renal failure is a rising public health concern, with diabetes being the major risk factor. Prevention and mitigation center primarily on traditional and now novel therapies like gliflozins and finerenone. At the national level, there is wider and more upstream adoption of multidisciplinary care paths. But I think that there are still some unmet needs of other innovations so that we can better apply more precision medicine in that regard. I thank you for your attention.
Thank you, Dr. Claude. Do we have any questions? Well, if not, as usual, I have a question. Thank you very much, Claude, for teaching me a new word today. Fluorinization.
Fluorination.
Or fluorination. I still haven't learned. Fluorination. So, in this war against diabetes with fluorination and ARBs, increasingly our patients with diabetes, these drugs actually present a challenge perioperatively for the anesthesia. Do you have any advice on managing these?
I think this is a very good question because even if those medications or therapeutics have been shown to have increased benefit in our population, there will be a group of patients you will have to be careful. And certainly patients going for surgery or being subject to anesthesia, one has to be extremely careful. So our advice to this patient is we will tell them if you're going for any form of surgery, invasive surgery, then they will have to hold it for some time. Because any form of stress have been shown to increase risk of euglycemic ketoacidosis. So similarly, we'll advise them if they are very ill, they're admitted to hospital with any other sickness, they have to withhold the medication as well.
Is there a time period where we need to hold them?
There's no size fit all, but usually about a week before and a week after. That's usually my advice.
Okay. And then, well, of course, we will have our anesthesia colleagues to see the patient beforehand, or they are nephrologists or endocrinologists. And otherwise, if not, then do we change their what would be a good replacement if we stop there?
Now, the interesting thing with the glyphosate is that they don't have that much effect on glycemic control. The HbA1c barely goes down by probably about 1 to 2% point when it's used. So in most instances, even when those patients are off it, it doesn't impact that much on their glycemic control.
Oh, that's excellent news. So we just need to stop it and then restart it at a certain time of the surgery. Okay, great. Thanks. Any other questions? Okay, if not, I'd like to thank both our speakers once again and close this session to provide time for the next one. Thank you very much.